Thank you, Sam. Good morning, everyone. We're so excited that you've joined us today for a discussion on our care management program, Care Navigation. Like Sam said, my name is Ellen Castor Porter, and I lead our channel management program here at Collective Health. I am joined, if you want to skip to the next slide, by two of my favorite colleagues today, Dr. Ari Hoffman, who joined us a few years ago from a clinical career at UCSF and currently leads both our clinical and our product teams. And then also Ben Becker, who is a nurse by training. He joined us last summer to further build and scale our programs. He comes with an extensive experience doing just that, leading all of enterprise care management at Intermountain in Utah. And they both can identify even more about their careers as they lead their sections today. So as I sort of kick us off, we work with brokers and consultants, clients around the country. I am calling in from the Midwest today from Kansas City. Ari's joining us from our headquarters in San Francisco, Ben from our Customer Experience Center in Lehigh. We're always so curious where you're calling in from. So as I sort of walk through the agenda, I'm hoping you could just drop in the chat. I know it's early, but navigate to the chat, introduce yourself, let us know where you're calling in from. It just is really great for us to see kind of who's joining us and from where. So as those come in, if you want to skip to the next slide, perfect. As you know, we're here today to talk about our approach to complex care management, share what we believe is the unique value of our program. And before I pass it over to our clinical team, I always find that it helps to put our program in the context of what Collective Health does more broadly. So on the next slide, you'll see this is our simple value prop. We deliver for your clients the power of carved out with the simplicity of carved in. We offer the flexibility to choose your networks, your point solutions, et cetera, and the convenience and ease of having that all in one place, having one strategic partner who can help curate these solutions for you to meet your needs. Our clients have always shared with us that being part of the Collective Health ecosystem gives them that unbundled approach that they were looking for with that bundled feel. So the next slide, I won't belabor too much, but this just shows exactly what we mean by that. So how to think about Collective Health, we are the TPA, which means that we do the eligibility, the plan design, we adjudicate claims, right? ID cards, everything you see along the left. But we're also the navigation. So all the digital tools, the human interaction, a lot of that we'll talk about today, the human interventions of our care navigation program. And then lastly, we are that highway that brings together all that curated ecosystem of partners, medical, dental, vision, et cetera. And some of you on the next slide might have known us from the beginning, back to our founding class of clients 10 years ago. Some of you might be brand new. Maybe this is the first you've heard from us or joined us somewhere with clients along this growth curve. What I like to call out here is that while we started as a tech company, mostly servicing other tech companies, we've diversified quite a bit, and we're seeing success in a variety of diverse industries and client sizes. This most recent one, most of the clients we onboarded were actually retail, grocery store chains, manufacturing, 17 clients in January and over 180,000 members, and it's been going really well. So we're excited that you've joined us here, that most of you are along with us on this journey, are hoping to join us on it. The one last slide I'll leave you with before going over to our clinical team is a question I get asked a lot when talking with brokers and consultants is, are you just another TPA? Do you compete with other TPAs? And the answer is yes, we are a TPA, like I said, but we're not just another TPA. For starters, we've raised $720 million of capital. There aren't a lot of other TPAs who've done that. Why did we do that? We knew from the beginning, our founders knew that to make this thing work, we needed to build our own infrastructure and our own tools from the ground up. You'll hear a lot of that today from Ari and Ben about what we've built in order to achieve these results. Along the way, right, the development of that technology created a handful and more of patents to our name. And those patents that form that technology have helped us integrate over 104 partners and more. And why did that matter? From the beginning, we wanted to do two things really well. If you advance the slide for me, from our founding, our North Star was, and it still is, member experience, right? Our early focus was high touch, high tech member tooling. We goaled ourselves on member satisfaction, our net promoter score. And then sort of the second piece, the balance to that was we knew we had to have a really good employer experience. Being an amazing administrator was part of that. So those were our two North Stars, and they still are our North Stars. And now we're in a position, right, to say, yes, let's keep that North Star, but let's goal ourselves higher than, member satisfaction. We're 75 plus NPS. We believe that's really valuable, and we keep that, right, as our bedrock. But, can we focus on clinical advocacy, navigation? Can we goal ourselves towards trend reduction also? And then on the employer experience side, we say, yes, let's continue to be an amazing plan administrator. Let's also focus on building innovative plan design tooling, things that, the industry needs that we're not seeing as much yet. So focusing on, building those innovative plans that improve satisfaction, reduce cost. And I do like to call out, that's why I sort of noted where we're all from. This isn't just happening in a skyscraper in San Francisco, right? This is in the last few years specifically, we've opened our Lehigh Customer Experience Center. We're opening in the next couple of weeks a brand new office in Plano, Texas, because of a lot of growth there. We've hired people from TPAs, from networks, from health system, from brokers, consultants, from clients to help us scale these programs, right? To bring that diversity of thought as we service more than 500,000 members to date. So in the end, I'll leave you with this before passing over to Ari. Collective Health is the sum of its parts, right? We think of us as the TPA, but we're also so much more, right? Focus on bringing those pieces together to help these plans perform across all of these really important metrics. And with that, I will pass it over to Ari to talk about cost containment.
Thanks, Ellen. Good morning, everyone. Thank you for being here. As was mentioned, I'm Ari Hoffman. I'm our head of product and clinical at Collective Health. And right there, actually, I'd like to just make a comment that we don't see those as distinct or different. We use a clinical lens through which to view our products and services that we bring to market. And we think that's really important to bring those things together. And we all know that cost containment is top of mind, especially as trend in the market has been so high in 2024 and is likely to be high again into next year. And that our clients are under tremendous value pressure to manage their plans and to increase healthcare value, right? So at the end of the day, I always think about this, how do we achieve better health at lower costs? So if you go to the next slide, there are only so many tools in the toolbox. And, there's choosing your medical network and the discount on the unit price. There's, maybe plugging in utilization management, different member engagement tools, pharmacy management, all these different programs and tools out there. And they're all important. But I think we all know that any one of them on their own is not as powerful as tying them together. And that's really core to our belief at Collective Health, is that we need to be able to put these things together to make them work best. And, one example there is just like plan design, value-based insurance design. There's some mixed reviews in the literature out there when it's done by itself, because sometimes it's done without real member understanding, real member navigation to help people make sure that people actually understand and know how to navigate those benefits effectively without stepping on financial landmines or, being penalized for things that they didn't know they were supposed to do. And so it really does need to tie together. And that's, if you go to the next slide, the way we look at this is that putting those puzzle pieces together rather than as one picture, rather than looking at each one individually, is a really core part of our ethos. So if you go to the next slide, I have the pleasure of handing off with that preamble. I'm going to hand the mic to Ben Becker as our lead on care management, and we'll answer any questions in the chat.
Thanks, Ari. And yeah, like was mentioned before, I am relatively, within the last year, new to Collective Health. Happy to be here and as the Senior Director of Care Navigation and trying to push what we're doing forward. If we go to the next slide, I'd like to just set off with a baseline as far as how do we define care management and how do we see it? And I see it as any effort to engage targeted members and population segments in order to guide them to higher healthcare value. So it's anything we're doing that's directing a member, a client, anyone to that higher healthcare value. And the way in which we do this, or the kind of the foundation, as we look at the next slide, is really most of us know that, and there tends to be a focus on high risk individuals, individuals that kind of fall into that high risk, high cost individuals with multiple complex conditions that require a lot of clinical support. That tends to be a small percentage of the population. On average, it's about 5%, but the spend, or where you're spending your dollars, it tends to be about 50% of the total spend or total cost. As we move down to the other areas, we look at rising risk individuals that have chronic conditions that are mostly managed or taken care of, make up about 30% of the spend and are 15% of the population. And then some of our episodic or acute situations, individuals just that have, something happen, they require a surgery, they have to go into the hospital for an infection or an illness, but are relatively healthy before that just make up another 15% of the spend and 30% of the population, leaving the majority of our population, that 30%, spending just 15%. As we look at care management, really what we're trying to do is get the right resources, the right attention to the right member or employee, get them the right care at the right place at the right time. And part of that is not just looking at that top part of that pyramid, those highest risk individuals, but really focusing a lot of our efforts, excuse me, a lot of our efforts and work on that rising risk and episodic, helping those individuals understand the healthcare system, helping them navigate that, helping them understand a new chronic diagnosis that is going to require medication management, maybe a diet change, and assuring that they are able to do that independently, and that it doesn't turn into something that they move from being, someone with a new chronic illness to being one of the high risk categories because they didn't manage their pressure or their COPD well enough, and it requires a more acute management at any point in time. So a lot of our work is areas of rising. We still are looking at and constantly trying to engage with or identify those individuals that are also that high risk. We target our patients, tends to be human with those higher categories, and use some of our digital methods or solutions, suggestions we call them, to go out to those individuals that are more healthy. So this is kind of the way we see it. We're agnostic. We're not judging one disease type. We target all of these patients in all of these areas, trying to get the right resources to the right individuals. As we move on to the next slide, a little bit about how it starts with identifying members or individuals that would benefit from care navigation services. We'll talk a little bit more about how we with ingesting prior auths and pre-certs, as well as into an identification capability. Then once we've identified those members that would benefit from our services, we have a team of clinicians that will outreach them, hopefully then engage them to make that difference. We implement multiple interventions depending on what that member's needs are and connect them to the appropriate care. Our goal in general is these individuals, teach them how to manage their own care and charge them, now capable of managing their care and know how to seek the value in their healthcare as they go forward. So as we move forward, I've mentioned our team several times. We are made up of a interdisciplinary team. Just move on to the next slide. That is consists of social workers, dietitians, pharmacists, nurses, and coordinators. The reason we have a multidisciplinary team because we firmly believe that, as most of you probably know, healthcare is not just the health side of it. We also need the medical side. We also need to focus on those social determinants of health and understand what's going on. Having a multidisciplinary team helps us connect members with clinicians best suited to that member may present with. And so this helps us and pushes us to outcome, engage with the members the way that they need it, and make a difference. Just focusing on social determinants of health, and even just in the past year, we've had 32 of interventions that just focus just on connecting individuals with community or other resources that help address those social determinants of health within our population. But if we can go to the next, as I mentioned, the way in which we identify members becomes key to a lot of this work. And the way in which we engage or identify members through what we call collective health cortex, it ingests, again, like I mentioned, a lot of that claims data, prior auth data, eligibility data, then helps identify members or individuals are in need of sort of navigation. Our care team then, with that identification, can reach out in most individuals as much upstream as possible. It may be we're in the hospital or that they've just recently been diagnosed with a chronic illness. Whatever that need may be, we're able to reach out and engage with them at that time. Beyond that, those triggers that come in proactively to us, we also, as Ari mentioned, we look at everything we do clinical lens. So we train our member advocates and those individuals just answering questions about the plan or things going on to be able to identify members that could benefit from care navigation. Somebody calls in asking, for a referral to an orthopedic surgeon. They know, oh, are you having a surgery? And you may benefit for that member now to navigation. We do a lot of work with our employers as well to push the care navigation product so that either members are aware, hey, I'm just having a hard time navigating, or this is new, self-refer as well. So again, we take all comers into that program to help help the best identify those individuals. If we then, I think I've got one more slide. As we look at everything together, so as we are able to identify these members, our engagement, then we use multiple methods to outreach or engage with members. We'll leave voice messages in case in the last year of being able to communicate with members. Within our portals, we're able to send
Hey, Ben. We kind of lost you there on audio, even with your video off. I think it's real shaky. You're getting, it was a little choppy, but now it's like we kind of lost you. Maybe I think you're about to hand it back to me anyway. Can everybody hear me okay? Am I coming through okay?
Sound great.
Yeah. Ben, sorry to do this. I think it was just a little too choppy. Maybe I'll just take this slide from you. But Ben and I are always mind melded, so I think we can finish each other's sentences at this point. But just the point I think you probably got from the slide itself is just that that we don't give up easily. We're really persistent at trying to engage members and thoughtful about the different ways that we do it, and work through multi-channel communication modalities to do so. We also partner with our clients because we recognize that different client populations have different preferences. We work with our members directly in terms of the configurations and preferences that they set within our member portal and mobile application, so that we can respect their preferences and engage them effectively. If you go to the next slide, I think So, you know, the idea here is just that our program is really designed for member needs, around member needs, and to benefit clients as well. You know, we talk about helping members live their healthiest lives and also tending to the bottom line for our plan sponsor clients. So we prioritize high cost and high risk areas through clinical gap in care closure, cost and quality data to optimize for members getting to high quality care connections. We can talk a little bit more about that if you have questions. We focus on specialty pharmacy, site of care redirection, you know, these areas where we can show hard claims savings in relatively short time horizons, while also recognizing that there are some investments in longer term population health and plan performance management that don't show up immediately, like getting people into primary care, for example, and optimizing the and rationalizing the use of virtual care options. We, as Ben was mentioning, with our identification and rules engine that we call Cortex, using different data sources to understand member needs, and really always trying to identify and engage early. So one of the metrics we follow is we look at those who became high cost claimants and how many of them were not identified by rules, by our upstream triggers. We know we're not going to get to 100% because there's going to be some people, you know, who have a traumatic injury, get hit by a bus, and end up in the hospital with a high cost claimant without really any predictor. But that number is hovering in the high 60s right now. And we're constantly asking ourselves, what are we missing? And then building new rules into our rules engine to move that needle further and further upstream. You can see some of the bullet points around our relationship with our members and our high cost claimant outreach. And then we think it's also really important, as I was mentioning in our puzzle piece slide, that to put these things together. So recognizing that what benefits are available, our Care Nav team, our multidisciplinary clinician team is also cross-trained as member advocates, as benefit navigators. So we're constantly also helping members not only recognize what the care plan is from their clinicians, from the delivery system, and help them adhere to it, and identify and tackle barriers like in the realms of social determinants of health and affordability, but also knowing how to navigate benefits and recognizing what benefits are available to that unique individual, where they are in their deductible, what if they have travel benefits from their employer, what point solution vendors are available at no cost to them, and have a bunch of different configurations depending on the client arrangement with those point solution vendors on the most appropriate referral pathways for members. If you go to the next slide, we know that, you know, we can talk a lot of game about the philosophy and the approach, about the engagement, but that at the end of the day, we have to prove the value of care navigation. So we want to spend just a moment talking about sort of how we assess the value of care navigation, and then open it up for questions. So in the next slide, couple highlights in terms of high level metrics on how we know Care Nav is working. High member satisfaction, really important care connections, effective care connections. So we see a 40% increase in Care Nav engaged members in primary care after engagement with Care Nav as compared to matched controls. And using a similar, the same actually propensity score matched approach to do precisely matched control comparison between Care Nav engaged and not. We see a $7,100 claim savings on average per engaged member due to care navigation. If you go to the next slide, I always like to also tell a member story just to like highlight how this actually works through the member journey and how Care Nav can directly contribute to savings. Now, this is a a case with a particularly large savings number in terms of the annual claim savings, $150,000 in plan savings through this particular member journey. And it just shows some of the highlights I'll walk through. So this is somebody with a chronic disease, autoimmune disease, who was struggling to afford and adhere to a chronic controlling medication and was suffering from worsening symptoms as a result. We, through a trigger, identification trigger, also, we don't just have these triggers go CareNav referral. There are very specific referrals designed to not only highlight what the potential intervention points are, the next best actions, but also through triage logic, route those referrals directly to the appropriate clinician type. The whole clinical team is available to wrap around that member's needs, but the primary clinician type is based on the triggers and the potential interventions and opportunities. So this one was a drug opportunity, so it was routed to a pharmacist who outreached and engaged the member, developed a rapport, education, talked about adherence and adherence barriers, got into the affordability challenges, assisted the member with finding specialists in different locations who they hadn't really plugged in with the right specialists to help manage their disease. And it turned out actually some of the pharmacists pointed out there's a concern about some of the medication dosing, and got them plugged in with a specialist who was able to adjust their dosing. The further assistance with expediting a prior authorization approval, which the member reported helped them prevent going to the ER and potentially being hospitalized. I will point out that's not part of our 150K calculus. We have held ourselves to the standard of not reporting on those types of cost avoidance metrics, but to stick to the actual claims experience, because we're administering and processing and adjudicating those claims. We have the data to assess that. And then facilitated a benefit switch from the medical benefit to the pharmacy benefit, a facility to home, site of service redirection, change some of the other medications, retail to mail and opportunities as well as part of a broader pharmacy optimization. Connected to various program partners that were available, point solution vendors, we call program partners, and then had a happy member with a happy outcome at the end of this journey. So if you go to the next slide, a couple examples of cost saving programming and sort of rolling that type of journey up to more aggregate data. Looking at advanced imaging, we see an average savings of almost $1,200 per successful conversion. And you'll see that that actually benefits both the client and the member. And with the split of most of that 800 of that for the client and close to 400 for the member on average. And we see about right now, this is 2023 plan year data, 1 in 5 members rescheduled their care due to lower cost imaging centers. So that was a 22% success rate. Specialty drug infusion, you'll also see a 1 in 5. These are separate analyses. It just came out to the same figure, 22% success rate. And the average savings is $21,000. As you saw in the last slide, these have a wide range, the specialty drug infusions, in terms of the opportunity for how much savings there is. And this is actually a cool one that I'm proud of working our data science team for. Like, they've really helped us think this through and work through some of the complexity around this. So we're now have built out a decision algorithm, essentially. So just to give you a sense, I'm sure you're all familiar with the complexity around pharmacy pricing and all the different options, but one member on one drug like Remicade at a hospital, there's 32 permutations for what could be done in terms of biosimilar availability potential, site of service redirection potential, swapping the benefit from the medical plan on the J-code on the medical plan to the pharmacy plan. It just gets really complicated. So we have trained algorithms to optimize for affordability in the same ways that we've optimized for affordability around advanced imaging. And we're really expanding and scaling that program in new ways this year. So I'm excited to see those numbers continue to improve. And then lab services, this is a smaller unit cost, but really high volume play, where we see an average savings of $47. Again, split with some member savings as well as client savings. A little lower success rate per outreach, really high outreach. So thousands and thousands of opportunities here because labs are such a common healthcare event as opposed to, say, a high cost specialty infusion. I know I'm talking fast. I'm going to wrap up here. So the next slide is an opportunity to hand the mic back to Ellen. I'm going to welcome questions both in the chat and in our Q&A session. Thank you.
Yeah, thank you, Ari, and thank you, Ben. Like Ari said, please, the main goal of ours is to have a Q&A with you. So please start putting your questions in the chat. While you're doing that, if you loved what you heard from the team today, you might be thinking, how would I know which clients would be a good fit for Collective Health? So as I mentioned at the top of the presentation, Collective Health is proud to work with a variety of industries and size clients, many of them joining us with different priorities. You'll see on here 3 different clients that we onboarded on 1/1. All of them coming to us, right? Sort of for different primary goals. Are this jumbo retailer, 50,000 EEs, looking to control costs, bring together all of their vendors through their program, looking to pair that with the high touch advocacy and navigation that you heard about today. A 1,300 EE tech client looking to reduce the day-to-day burden for their already pretty stretched benefits team through the administrative lift functions that Collective Health offers. And then lastly, I love to call this one out. We love working with our brokers. I love working with our brokers. We love having them as clients too. So we onboarded a broker who wanted to sort of road test strategies that they're recommending to their clients. They found Collective Health to be a really good chassis to be able to experiment and kind of test things out before they brought them to market. So finally, on the next slide, if as you head into your strategy and planning sessions with your clients, some characteristics just to listen for and to look for that would make a really good fit for RFP to Collective Health. We tend to find that we play best in the above 1,000 EEs. That's where our pricing starts to make the most sense. Clients who are looking to carve out their PBM, add point solutions, looking to control costs, and looking for that member experience. If they have or are exploring Quantum Accolade included, right, our navigation and advocacy is in direct competition to those. And so any of those clients. And then lastly, just anyone who's looking for that flexibility, but still with a bundled feel and all the benefits that come with that. So finally, on the last slide, like I said, my name's Ellen. It depends on where you're located, and our sales team is aligned by region and then also by house. So I think the best thing, if you would like to learn more, if we could get in touch with you, please send me an email. You'll see my email on the screen, ellen.porter@collectivehealth.com. I would love to introduce you to the right people who can move this conversation forward for you. You'll also receive a follow-up email from our marketing team, so you can feel free to get in touch with us there too. And I think we'll move to the Q&A portion. There is a great question in the chat. Ari, I'll turn this one over to you. Do you engage the providers as well? How do you smoothly transition the member to better care or more cost-effective care?
Yeah, I just typed an answer, but I'll speak to it and elaborate a little further as well. So it's a great question. We do engage providers, and especially interventions that require provider behavior change, right? So for example, prescription, if we need the provider to write a new prescription, we know that's not we can't just like text the member or like send a message to the member and say, hey, like go get a different prescription change or like a different site of service. Like moving a specialty infusion from the hospital to home is not something that we expect members to be able to just navigate on their own. So we do engage providers for those. We've iterated a lot on this, and like a couple of fun examples of our learnings. Like one was, so one is, Ben and I both come from the delivery system side. We have a fair number of providers in our company, and I think that helps us understand provider behavior. A lot of my work at UCSF was around provider behavior change as well, and so one of the things with prior authorizations that was an interesting learning was like there's just no real incentive for the provider if they've got a prior auth approval for say 6 months of a high cost infusion, then they're often not motivated to do any work right now to change anything. And so those conversion rates, like if they had a couple months left on a PA, we were seeing that those conversion rates were lower. And so we set some reminders and alerts in the system for PA expiration as an opportunity, upcoming PA expiration as an opportunity to get ahead of it for providers and help them navigate. And providers do relate to patient affordability, patient convenience. So like even if the health system has an incentive to keep people within a hospital, a facility-based infusion center, the providers themselves are often really much more motivated by the patient preferences. And so having linked up with the patients or the members that way, we find our engagement rates with providers going up quite a bit, and the conversions are healthy as a response. Probably more than you needed, but.
No, that was great. Thanks, Ari. Sort of a follow-on to that question in the chat is, what data do you use to qualify providers as cost-effective, or so how are we deciding what is high in quality?
Yeah, great question. We are launching a new provider level quality scoring system on Monday, actually. So I'm excited about that. We are using a vendor relationship, and so that information is available to us on the back end for analyses related to the appropriateness, clinical quality, and cost efficiency of providers at the provider level. And I actually think that's really important because some of the historical work around facility focused or group focused scoring fails to acknowledge that there's a lot of variability within facilities, within health systems, within groups even. And so, we're really trying to get people to the highest value providers and do that early in the journey, especially for those journeys where we know we can make a big impact on a musculoskeletal journey. For example, like, I have knee pain right now because I'm in my 40s and playing soccer and tweaked it, right? And I just think about how many people, and we watch in the data, how many people go straight down a really aggressive path. Like they're at orthopedics immediately, they're getting an MRI, they're considering surgery, when the vast majority of like low risk musculoskeletal pain can be dealt with time and physical therapy, and save a great deal of potential complications, not to mention money for both members and plan sponsors.
Fantastic. Another question that just came through, Ari or Ben, if you can still hear us, what disease categories do you see CareNav excelling at in our data? Are there specific areas where we find that we're more effective than others?
Ben, do you want to test your audio?
Test, can you hear me?
Sounds okay right now. I'll let you know if it cuts out.
Oh,
Oh, nope. Not working.
Okay, sorry.
That was immediate. Apologies, everyone. Thanks for bearing with us. And Ben, I'm sorry. I love to share the stage with you. I feel like I'm stealing your thunder. And so the question about different disease categories. So this is a great question. We actually looked at this with an independent third-party study of our impact on cost efficiency over a 5-year period, and then broke it down by different disease states. And so we saw the biggest impacts in hypertension, metabolic disease, including diabetes, and musculoskeletal disease. And we sort of broke out back and joint disorders, really big impacts in both of those areas. Sizable impacts on mood and anxiety disorders as well, with respect to cost efficiency over time. So we were happy to see improvements across all 10 of the most prevalent condition states. But in particular, the ones I just mentioned were the strongest.
Fantastic. We talked a lot about value today, Ari, of our program and sort of the details of our program. This question is, if you could just elaborate on what makes our program different than others that are being sold to these folks in the market.
Great. I mean, I think first and foremost, I do think it's the tying together of all of the pieces. I think I go back to our name, the collective health, putting it all together is really critical to what we do. And I'm really excited about some of the ways that these pieces are actually coming together in new and interesting ways too. Like, you talk about provider level quality scoring, you talk about tiered plan design, and pretty soon you can talk about quality-based tiering and the opportunities there. But again, I think it's critical to tie that to digital tools that are intuitive and easy to use, language that's understandable and straightforward and simple. I mean, how many people really love reading an EOB and like understand what DME means? And we don't speak that language to people. We speak human language. We don't say DME when we can just say breast pump. And if that's what you're looking for, that's what we're going to help you find. So, and I do think that stuff sometimes gets overlooked. All those little details, when we start talking about these big levers like, care management, utilization management, plan design, those are important levers, and we pull all of them. I think the tying together, though, comes with having a foundation of trust on which members actually look to us for help. And I still go back to some of our really high level stats and metrics that we track around engagement, having over 80% of households registered, having, 70% of claims preceded by engagement with us. The fact that people are looking to us, and some of it is the logistics, right? The fact that we administer the plan and that the card is in our app, like people are coming to us in various ways and creating all these opportunities for us to interact with them in meaningful ways that tie together the plan, the UM, the CM, payment integrity, all tied together, so that we're not just like pulling a lever over here and then a different lever over here, and it's pop health in this corner and it's cost containment in that corner. It all has to come together, because at the end of the day, members are people and they're living whole lives. And so I think that's what puts us apart.
Fantastic. I think that seems like a great way to wrap it up. I know we didn't have a ton of time together today, but we just wanted to thank you all for joining us. Again, my name's Ellen Castor Porter. You see my email here on the screen. We would love to get in touch. You told us at the beginning sort of what regions you're in. Like I said, we have clients all over the country. And so I would love to put you in touch with the right person to continue that conversation. So that's ellen.porter@collectivehealth.com. Or if any further questions come up, please feel free to shoot them my way, and I'll get you in touch with Ari and Ben as well. So with that, Sam, I think I'll pass it back over to you to close us.
Sounds great. Thank you, everybody. Excellent job. Thank you so much for joining those in the audience. Friendly reminder, you have an opportunity to take a guided tour of our employer and member platforms with Collective Health Expert as well. Just shoot us an email, and then once the webinar closes, just take 30 seconds to fill out the survey. It shouldn't take you long. Other than that, we hope you have a great rest of your week. Thank you so much.